Welcome to the annual general meeting of the Aneurin Bevan University Health Board, which will cover the financial year 2021-22. Croesawu I chi gyd I gyfarfod cyfarfodynol blynyddol Bwrdd Iechyd Prifysgol Aneurin Bevan sy'n cwmpwsau flwyddyn ariannol 21-22. This is going to be via live stream, and I hope you find that you can accommodate the medium and this will allow you to properly scrutinise the AGM. 21-22 has been an absolutely remarkable year. We have all had to work very differently. People have accessed care very differently as well. And I'm really grateful to members of the public for their help and support during that time, because it has been truly difficult. The achievements of the health service and the public and voluntary and third sectors has been outstanding. You, the public, have responded so well to the increasing requirements of passing through COVID and then recovery, and you've been really resilient in the face of change and uncertainty. And we would like to thank you very much for the continued support and encouragement that you provided both the Health Board and our staff in order to recover the services on which you depend. The annual report will show the exceptional achievements of individuals and services to deliver healthcare despite those challenges. I think it's really great that we're in a position to extend our thanks to our staff and to you all in order to achieve what we have tried to achieve. I know some of you will have been disappointed with our response, but we are working diligently with you and the CHC to make sure we can recover our services as best we may, and we're all working really hard to do that in order to meet your needs. We welcome questions from staff and members of the public, and thank you very much indeed to those of you who have already submitted your questions. We will obviously answer some of those at the end, but we do encourage you to continue to submit your questions. If we're unable to get round to answering you now within the next hour, then we will make sure that you receive a copy of the response tomorrow. And I hope you will bear with us in that. So thank you all very much indeed for attending today. And I should like to hand over in the first instance to Glyn Jones, our interim chief executive, who will take us through an overview of the Health Board's performance in 21-22.
Diolch, Cadeirydd, pnawn da pawb. So thanks, Chair, and good afternoon, everyone. I think, as our Chair has indicated, these have been incredibly challenging times. But I think despite this, the Health Board has continued to deliver against what I think is a very complex and wide-ranging agenda, with a number of positive outcomes evident, given the circumstances that we've been operating within. If you can move on to the next slide, please. I'm really delighted to be able to present an overview of the Health Board's performance during the last year, 2021-22, and I will briefly run through just a few slides, as I know that some of my Executive Director colleagues will cover some of these in more detail. So just a few of our achievements that I wanted to sort of highlight. First of all, we ran a hugely successful COVID-19 vaccination programme with around about 1.3 million vaccinations administered. We also undertook over 1 million COVID tests, and I think these are phenomenal figures, really, when you think about the volume, but also the pace at which we had to deliver these services. And the fact that this was really critical in our fight against COVID and keeping our population as healthy as possible. Of course, COVID was not the only infection that the Health Board has had to deal with, and I'm really sort of pleased to be able to report that for 2021-22, we reported the best performance across NHS Wales in terms of infection control indicators in 5 out of the 6 indicators that we measured against by Welsh Government in relation to reducing infection in the NHS. So whilst COVID has had a significant impact in terms of death, the overall performance in terms of mortality is relatively positive. And again, we'll cover this later in some of our presentations. We've also seen significant reduction in the overall vacancy rates across the Health Board, and I think the Grange University Hospital is proving to be a big attraction factor in terms of recruiting new staff. And I think, generally we get very positive feedback in terms of staff wanting to come and work at the new hospital. Also, I think it's positive to report that the Health Board achieved financial balance during the last financial year. Again, I think a significant achievement given everything else that we were trying to deal with. And I know that Rob Holcomb, our Interim Director of Finance, will provide more detail later in the AGM. So I'd now like to just provide a few examples of some of the achievements against our sort of 5 priorities in the IMTP. Each priority having a number of objectives. So if we take the first one, which is priority 1, which is around giving every child the best start in life. Again, you can see on the slide a number of the key objectives that we were looking to deliver against. I won't go through all of these, but I think it's important that we can demonstrate achievement despite the context of last year. And in April 2021, we launched our new Healthier Together website, which was co-designed by parents and healthcare professionals and provides a range of information, signpost people in terms of where they can get help and support. We've been working closely with women during pregnancy to promote health and well-being, which we know has had an impact on the life of the child. So again, really, really important. And also, I would like to mention the work that we're doing on healthy weight through pregnancy and smoking cessation. If we can move on, please. The next priority then was around getting services right for children and young adults. And again, a lot of work took place last year to both improve services, but also recognise the increased demands that we saw, partly in relation to the COVID pandemic. A number of areas, but particularly wanted to mention space, which is the integrated single point of access, focusing on mental health and emotional well-being for children and young people. And this is very much an integrated piece of work. Excellent example, I think, of effective partnership between local authorities, schools, sports and leisure, and obviously the NHS. We also integrated our children and adolescent mental health services and the primary care mental health support service to try and generate more seamlessness for young people accessing those services. Again, if we can just move on, please. Priority 3 then was around adults in Gwent living healthily and then ageing well. And again, I think you can see from the slide there are a number of achievements, some of which I've mentioned earlier around COVID testing and vaccination. But I also wanted to mention some of the other services that we provided, particularly in relation to mental health, with the introduction of our sanctuary model in ED, which was launched back in December 2021, and also the implementation of TCANO, which provides an alternative to inpatient admission, as well as our Shared Lives programme, which relies on families hosting a person in mental health crisis but again provides a really good alternative to admission to hospital. Priority 4 then is around older adults supported to live well and independently. And again, you can see from the slide here some of the achievements and improvements that we've made. Again, really important to say that this can only really be successful if we work in partnership with local authorities, the third sector and other stakeholders in achieving better care for patients accessing these services. And then finally, priority 5, which is dying well as part of life. And again, you can see that there are a number of areas here that we looked at in terms of delivering better end-of-life care for people in our communities. And obviously a key focus as we move forward is further progressing the use of advanced care plans. So again, I'm conscious of time, but I hope this gives people a brief overview of some of the very positive outcomes and achievements that were delivered across the Health Board area during what I think everybody would agree was a very challenging year. So finally, I'd just like to say thank you, Diolch yn fawr. I think, first of all, I'd like to thank our staff. They always amaze me by their ongoing hard work and dedication. I'm really, really proud of the way that our staff have responded, not only last year, but during what is probably the last 2.5 years of the COVID pandemic. And they've done this knowing that they're trying to provide the best possible care during such challenging times, which I know will continue, but I've got absolutely no doubt that our staff will give their all in terms of delivering good quality care. Now, we know the Health Board is part of a wider system that provides health, social care and other vital public services to our local communities. So working collaboratively and focusing on integrated, seamless services has become increasingly important as we face greater demands on our respective services. So I'd also like to recognise the work of our partner organisations and their staff for collectively delivering these really important services over the past year and more. And I would finally like to acknowledge the support of Welsh Government colleagues in working closely with us and supporting us, I think particularly in our local response to COVID and all the other demands that have been faced by the Health Board. The financial support and various other support that's been provided, I think has been really, really important to allow us to focus on what we've really had to focus on. So diolch yn fawr, thank you so much, everyone. I will now hand over to Nicola Prigodic, who's our Director of Planning, Performance, Digital and IT, and Dr. James Calvert, our Medical Director. And they're going to discuss some of the progress on our clinical future strategy, including the 12-month review that we undertook following the opening of the Grange University Hospital.
Thanks, Glyn. And it's a really good opportunity to share with you some of the work that we've done around the reflections and evaluation of the model that we put in the middle of the pandemic and with the opening of the new Grange University Hospital. Just in terms of the summary, what we did a very comprehensive review, reviewing the first 12 months of operation of the new hospital and the new model. We took a decision as a Health Board, a very careful decision, clinically led decision to open the hospital earlier than planned in the middle of the pandemic, because we felt it was a significant contribution to our COVID-19 response for the winter of 2021. And what this kind of presentation does is share some of our high-level system reflections, some of the demand changes we've seen, understand the context with which we were working in, and what some of those kind of key outcomes and key measures are telling us. And I'll be handing over halfway through the presentation to Dr. Calvert in terms of who's going to share some of those patient outcomes. So what I wanted to do was kind of take us back to some of those kind of the case for change right at the beginning around when we had this new hospital. I think it's just important for us to recognise that We have had significant attention on the new hospital since it's opened. It is important to remember we have opened up the new system in the middle of a pandemic, but it has been of huge political interest and public interest, and therefore even more important for us than normal to make sure we've got that evidence base of our evaluation, to make sure that we are confident the system is working as intended in the context of the pandemic situation that we faced. So just first of all, this is the case for change in terms of when the business case for the new hospital and the new clinical futures model is put forward, and in terms of what we were intending to achieve from this new system that was very much part of the public consultation. We were looking to improve access and times for patients in terms of both planned and unplanned care, in line with the national targets at that time was in 2015. We were looking to achieve and exceed, when possible, some of the minimum quality standards for healthcare and improve outcomes for our population. As part of that model, even though we were centralising many of our key critical acute services into one hospital, we, alongside that, looked to improve our, back to the other slide, to improve the local provision of services and minimise the travel times for many services by local general hospital, community-based services. And by that new hospital, we knew a lot of our estate wasn't fit for purpose. So part of this was about putting a new purpose environment in place that was of modern day accommodation. Many of our workforce were struggling. We had lots of services that weren't sustainable across 2 sites, and this new model would give us resilience that complied with many of the medical deeming requirements and European time directives. And finally, where we possibly could, we were looking to be best in class, upper quartile performance on all the key performance indicators. That was very much how we'd embarked on this this new project. And then obviously we had approval for the new hospital back in October 2016, and we were mid-planning. We were progressing really well with our plans and due to open the hospital in March 2021. The next slide is done. And we were faced with a position with the first phase of the pandemic where we felt we potentially were going to need thousands of beds across our health system. And we were in a position where we worked with Lang Roke supply chain partners to escalate the potential use of the ward areas of the new hospital by the end of April 2020. Fortunately, we didn't find ourselves in the position of needing that as a result of the interventions around lockdown, etc., which helped to slow down the spread of the pandemic. But what that did do was put us in a much better position to consider whether we could open the whole hospital earlier than planned. And all the evidence was telling us is that another wave was likely and that we were going to be faced with a significant challenge in a second wave. So we held some clinical-led sessions. We did a risk assessment based on what we were faced with. And the case for opening the hospital early was we knew we would get service sustainability for some of our critical services. Our women and children's services were facing significant risks. It was already fragile, and we had new workforce challenges and less space because of the need to spread our services out because of the infection control. We would have a new large critical unit that was single rooms, but also have the space in the single rooms to double up patients and enable the whole critical care team to work in one area and not overflow into recovery areas or any space people were finding, which is what we were faced with in the first wave. We would have 75% of our rooms in the hospital were single rooms, which for an infection control environment was a huge benefit. Oxygen capacity was a key constraint. That oxygen tank in the Grange was almost like gold. It was such a huge asset for us, and to be able to have that resilience. It also enabled us to really try to escalate and expedite some of our transformation opportunities. And just the opportunity to centralise those services that we knew were struggling, not in terms of workforce, but space as well, like critical care I mentioned, but emergency departments, theatres, women and children. The clinical consensus was that the benefits of opening early outweighed the risks of not being as ready as we would have liked to be. So it's if I just take you through in terms of what happened in terms of demand. We've seen a huge reduction in demand when COVID first hit. We know people weren't presenting to hospitals in the way that they used to. Some of our services had to be stood down. But if you kind of go halfway across the graph, as you can see on the right-hand side, we opened the hospital literally a week before that bottom peak. We just about did it in time, really. And then that huge kind of line that almost goes vertical up the middle of the graph was the first 6 months of us opening the hospital. So from the middle of, we hit the peak of the second wave, and then just before Christmas in December, where patients just kept coming in terms of their COVID presentation to the acute centre. And we had to respond to that increased demand while we opened that new hospital. But what we did have was an increased resuscitation area for those highest acute patients. We had a critical care department that could cope, and we had respiratory on site working really, hand in hand with the critical care team. So our ability to respond to that, but that huge, and what you can see even since then, we've seen volatility in demand. So it did a huge peak back in around June 2021, where I think we've seen the highest presentation of attendances on record at our ED department. Then we've seen a gradual decline. I think as we hit the Omicron, we've seen reductions again. And then since then, we're having to meet with our increased demand again. So it's an important context that we've not only opened a new hospital, but we've tried to do that with this huge volatility in demand and a change in the acuity of demand that's been coming through, where we have seen many people who possibly during the restrictions and the lockdown not presenting in the normal way. And therefore, when people were turning up, we were seeing a higher level of acuity. Cardiology, emergency surgery are two specialties in particular where we've seen a significant increase in presentations at certain peaks at certain times. So moving on. So in addition to that broader position of demand, we were also expecting our populations to be able to understand how the new system worked, and despite huge amounts of communication efforts and leaflet going to every house, it's only often when you need to use the service that you try to navigate it. And despite the best signposting, we have seen more people presenting themselves to the ED rather than coming by ambulance. And those activities, we were predicting around 167 attendances per day on average. The range has been between 88 and 280, with regularly 220 people presenting themselves to the A&E department. What happens in those situations is often people who are presenting themselves are more seriously ill than those who come by ambulance, and therefore often requires a prioritisation of those who come themselves, and that's led to many ambulance delays. We obviously, we've seen some increased paediatric attendances and some of our GP referrals compared to pre-pandemic levels. I've just mentioned some of the acute specialties. And what we've also seen is the number of patients who are staying more than 21 days in our system. Some of that is because of the acuity, some of that is because of the pressures we know our social care partners are facing in terms of their challenges as well. And that has meant our hospitals are fuller than that we've got the capacity to, that also leads to a lot of pressure at the front end of the system. So I think in terms of what has gone well, and when we've done our evaluation of 12 months on, and trying to evaluate whether the system has worked whilst also responding to an unprecedented pandemic challenge is quite difficult, but we've absolutely tried to do that. So I think in terms of what's gone well, we've absolutely seen much more service sustainability for women and children's services, particularly around medical staff for paediatrics and obstetrics, which are some of our key risk areas. We've got a much more resilient and flexible critical care service who've really settled well into the new unit and really looked to optimise that facility they've got with the state-of-the-art equipment. We've got improved infection control management. I think, as Glyn just mentioned, we have 5 out of 6 of our metrics are generally the best in Wales. We've got much more resilient specialist acute services than we had pre-pandemic. We've got additional space. So we've got additional space in terms of critical care, additional resuscitation capacity, additional ED major spaces. But we also, by coming out of those hospitals, created more empty ward areas that enabled us to kind of branch out into when we were trying to manage COVID outbreaks, and has given us much more flexibility than we would have otherwise. We've seen improved recruitment, again, as Glyn mentioned, in many areas, particularly in specialist medical staff and registered nursing at the Grange. I know there's waiting lists for our critical care nursing vacancies. And many of our consultants are particularly attracted to the state-of-the-art environment and equipment, and many very supportive of the model with which we are implementing. And the other one is our ability to maintain elective work at times of high emergency demand. By that separation of elective work at the Royal Gwent and Ever Hall away from the main acute emergency site has enabled us to continue with our elective activity, which often in situations of high emergency demand, we in the past have previously had to cancel. So it's really helped us maintain some elective activity at, in those occasions. And we've got increased diagnostic capacity, 12 new pieces of high state-of-the-art kit in the Grange University Hospital, and we've not decommissioned any of the facilities at the other hospitals, albeit they're slightly different opening times. So that's enabled us to maintain a strong diagnostic response as part of this whole, as part of our sustainability going forward. So but we know it's not been challenge free. There's been significant challenges for us. Not first of all, just in terms of managing the whole demands of COVID. We had to literally reconfigure parts of the new hospital. We had to convert one of our wards into a COVID A&E department because we needed separation in terms of protecting our patients. We had to have testing regimes. We had to colour code ward areas in all our hospitals. We weren't only trying to get patients into the right place, we had to try to get them in the right place in the right area with the right colour. It was extremely challenging for us. And trying to maintain all of those different pathways, and staff absence was a huge, our staff not only delivered in this, but they actually introduced the new model and opened a new hospital in the middle of this. So we were also dealing with the pressure on staff. I mentioned the patients and professionals navigating the new system. We've continued since we've opened to try to reinforce the message of where best to go. We are seeing evidence of less people needing to be redirected, but we've still got a lot more work to do to help people with that. Our biggest challenge as well has been around the fragility of the workforce at our enhanced local general hospitals and our community hospitals, particularly around some of our medical staff and some of our nursing workforce as well. So that's been a key area of focus, and I know James has been working really hard with the deanery as well in terms of making sure we can offer really good training experiences for our doctors, whichever part of the system they work in. Patient transfers has been a key focus for us as well. We've had more patient transfers than we planned, and a lot of that is because of the pandemic. So our system was designed to transfer people out of the Grange when they were well enough to go. They go closer to home and to a hospital or a service that was more suited to their needs at that point. We've often been transferring patients 2 or 3 times as they went through their COVID kind of journey. People might have left the Grange, gone to a local general hospital. Once they got post 14 days and were ready to go home, they went to another hospital where we try to cohort our non-COVID patients. So much of that was driven by the pandemic and the infection control requirements. And that's not in an ideal situation that any of us would want longer term. So we're really looking at how we can streamline those patient transfers. And linked to that, patient experience, we know has suffered during this time. People have waited longer than we would like them to, and communication methods, especially when we first opened the hospital. We've always had full operating Wi-Fi, but our mobile telephony services came a bit later. We knew we had staff under huge pressure, so some people couldn't visit their loved ones, and obviously they weren't getting some of their calls answered. And we did quite a lot of interventions to try to help that once we were receiving that feedback in terms of ward assistance, a patient liaison service, to really try to help address some of those patient experience issues, which we know cause a lot of distress for families. So they are kind of the broad high-level system reflections. James is going to pick up a couple of specific patient outcome and clinical outcome related measures that help give that data and evidence as to whether the system is working clinically. James.
Thank you very much, Nick, for taking us so clearly through a lot of complicated information. But in summary, what I'm going to describe to you now are the benefits that have accrued to our local population from the work that was done to concentrate teams in a specialist hospital to provide complex care to our sickest patients, and the same work that was, or the work that was carried out in our ELGHs, our local hospitals, to ensure that patients continue to get the aspects of care that didn't require that super specialist input to a high quality in their local area. Now, some of the data I'm going to show you is a little bit complicated, so I'm going to talk you through it very carefully. So if we could move to the first slide, please. Now, this describes a metric called a RAMI, and RAMI stands for Risk Adjusted Mortality Index, and it is a measure of how likely you are to die if you are admitted to our healthcare system. And it's a recognised way of looking at mortality, and the calculations are carried out in such a way that it allows you to compare your performance with the performance of other similar hospitals. So if I draw your attention first of all to the graph on the right hand side, this is a graph called the funnel plot, and those two black lines that you can see in a funnel shape describe the upper and lower limits of what would be considered as acceptable performance. And those green dots that you can see on the slide represent the performance of lots of individual healthcare providers across the United Kingdom. And the dot that describes the Aneurin Bevan University Health Board is that blue dot that I've indicated with an arrow. If your dot lies above the upper black line, it means that you are more likely to die than you would expect if you were admitted to that healthcare provider. If the dot lies below the lower black line, it means that you are statistically significantly less likely to die. Now, what isn't showing well on this graph is that centre green line that Aneurin Bevan University Health Board sits on very comfortably. And that line lies at about 95. Now, this is an index, which it means, so the numbers have been adjusted so you can make direct comparisons. And if you have an index of 100, it means that your risk of dying is exactly what you would expect, given the physical and age characteristics and age makeup of your population when compared statistically with other similar populations. So I'm really pleased to see that AVUHB sits on that green line with a mortality index of around about 95, which means that given the makeup of our population and given the healthcare needs of our population, the likelihood that you will die if you're admitted to our system is about 5% less than you would expect, given the severity of the illness you're presenting with. Now, that right-hand graph doesn't really reflect the extent of the achievement. I'm going to draw your attention now to the graph on the left-hand side. Now, this is called a Q-sum graph for people who are interested, but essentially what it is a graph of the calculated expected risk of dying for the people admitted in any given month against the actual measured death rate within the hospital. And what you can very clearly see is that month on month, over the course of last year, the risk of dying in the health board fell a little bit. So this is a comparison month by month of the expected mortality against the observed mortality. And you can, as long as the line varies between the upper red line and the lower green line, you can conclude that there is no change in the overall pattern, that it just constitutes normal variation. So I was delighted to see that about halfway through last year, the blue line consistently went below the lower green line. And what that suggests is that we're on an improvement trajectory for steadily improving mortality within our health board. So we're already in a good position and we're improving. So if we look on at the next slide, we can begin to get into some of the detail. So the first sort of graphs I'm showing you here are our performance in one particular clinical condition, in this case, our performance around hip fractures. And probably the most important graph here is the one on the left-hand side, and I draw your attention to the red dotted line. So one of the things that we know very clearly is that if you have a fall and you break your hip, the sooner the hip is operated on, the more likely you are to have a good outcome and to become mobile as quickly as possible. And as far as possible, the standard is that you should try and operate on people within 24 hours of their fracture. So you can see that that steady downward trajectory is really encouraging and will play out as better outcomes for our patients. And that improvement is only possible because of the concentration of highly skilled staff with modern equipment in a purpose-designed specialist hospital. So we just move on to the next slide then. Falls is an area that we think about. Obviously, a fall is one of the things that often leads to a hip fracture. And one of the things that we know as a health board is that the number of people in our communities that fall is higher than we would like. So one of the important public health areas that we'll be looking at over the next few years is how we can identify people at risk of falls in the community before they fall, and to provide an intervention that will hopefully reduce that risk. But we also know that people are at risk of falling when they're in hospital, and that's one of the reasons why we're always so keen that people should get well quickly and get home, because being in hospital exposes people to lots of hazards that they aren't exposed to at home. An increased risk of falling is one of those risks, but also an increased risk of infection and deterioration through disruption to people's normal daily lives. So the graph on the right-hand side doesn't really adequately reflect the immense amount of work that has been undertaken by nursing staff on the wards who do the falls risk assessments, therapists who help people to mobilise, and doctors who critically review patients' medication charts to make sure that we reduce as far as possible the risk of falls. But all of that work has led to a significant, statistically significant reduction in the risk of falls for inpatients in the health board over the last 12 months. And that's a trajectory that we're all committed to continuing. If we move on to the next slide, please. So these two graphs here, it's another funnel plot, and the graph on the left-hand side looks at performance in 2019-2020, and the graph on the right-hand side looks at our performance in 2020-2021. And unfortunately, I didn't put blue lines on the graph here, but the story is a consistent one across this whole period, that we've been able to maintain good stroke performance. So our blue dots that describe the care for our health board lie very close to that bottom line, which means that we're within the control limits, but also we are beginning to edge towards even better outcomes than we would expect given our case mix. And this is something that we're very proud of, but not something we're complacent about at all. The significant pressures that have been placed on the Grange Hospital in the last 12 to 18 months mean that we have a constant challenge to ensure that the right patients go to the right place in our system, so that we can continue to sustain these good outcomes, but so that in the future we can improve them, so that Q-sum graph I showed you right at the beginning continues to improve with time, because I would aspire for us to be the safest hospital in Wales and one of the safest hospitals in the United Kingdom. Next slide, please. So the modern healthcare facility that is the Grange University Hospital isn't just about fantastic equipment. It isn't just about fantastic teams working together for patient benefit. It's also about the benefit of having a modern building designed to the high standards, reflecting the research about what good modern healthcare facilities look like. And one of the biggest challenges we've had as a healthcare system, as every healthcare system in the world has had during COVID, is minimising as far as possible the likelihood of someone catching COVID whilst they're in hospital. And there are so many aspects to achieving that. One of them is exemplary infection control performance from our staff and the behaviours they reflect every day. One of them is good healthcare planning to make sure that we maximise the utility of the buildings we have. But ultimately, you also need a purpose-designed. The Grange University Hospital has a significant number of side rooms with ensuite facilities, which has given us a lot of flexibility in managing infection control well. So you'll see on this graph that the red dotted line reflects the healthcare acquired COVID for GUH. The orange line is the Royal Gwent, and the grey line is Neville Hall Hospital. And you can see very clearly here that far fewer patients acquired COVID whilst they were in the Grange than in the other hospitals. And one element of that will have been the design of the building. Now, of course, there are lots of other aspects to that. Patients' length of stay in the Grange tends to be much shorter than in the other sites in our health board because of the purpose that the Grange Hospital has within our system. And that, of course, gives people less opportunity to catch an infection because they're in this for a shorter time. But I'm certain that the design of the building also provided a beneficial effect and provided a benefit to our staff and local population. Next graph, please. So in summary, from the first part of my presentation, mortality has fallen since we've been in the new system. We were always well performing within Wales, but things have improved. The outcomes from strokes and heart attacks are within the expected parameters when we compare our performance with the performance of other centres in the UK. The hip fracture data shows that we're meeting all 6 key measures of quality around caring for patients who've had hip fractures. And then, as I also mentioned, falls in the community are higher than we would like, and that's something that we will work to do something about in coming years. But we have seen a reduction in the number of falls in hospital, and all of us have benefited from the improved infection control environment in the Grange. Next slide, please. My belief, though, is we can't say that we provide really high quality healthcare unless we have the good outcomes which I've described. But we also need to offer a very good patient experience. And we know that that's where we're really falling down at the moment. All of us will have seen the news and seen ambulances queuing outside our emergency department, and people will have heard discussions about the difficulty we're having helping people back to their homes after they're medically optimised for discharge. And all of those things lead to people spending longer away from their homes and their families and their friends than they'd like. We also know that COVID pressures have led to increased waits for operations and increased waits for outpatient clinics. And all of these have a negative impact on the well-being of our population. So I wanted to reassure those listening that we are proud of the good clinical outcomes that we have. We're not complacent about them. And we want them to continue improving as they are. But also we're very well aware that we also have to make sure that the people coming through our healthcare system get the very best experience every time. And whilst we receive a lot of feedback from the public about good experiences people have had, we know that that isn't universal, and we're committed to improving that. Next slide, please. So one of the key things that we'll have to work on in coming years is ensuring that we have lots of very high quality alternatives to hospital admission, because we know that a lot of people don't need to be admitted to hospital to get a good outcome and to recover rapidly from their illness. And that means that we're going to have to work with our local populations and work with our staff to design services that allow people to be cared for either in their own homes or as close to their homes as possible. And there are lots of enablers to that that we're working on very actively. One of them are services that we're redesigning to help our older and frailer patients to get care closer to home, because we know that they're a group who suffer particularly if they're in hospital for an extended period. We're also aware that whilst we have an excellent healthcare system, particularly at the moment, it can be a little bit difficult for patients and professionals to know where to go when they fall ill to get help. So we put in place a system called the Flow Centre, which is accessible by professionals from across the system and from NHS 111, so that we can provide expert advice to help people navigate to the right part of the system first time quickly. We're also working actively to implement Welsh Government policy around urgent primary care centres, which I think are a fantastic initiative. And the urgent primary care centres are now seeing over 8,000 people a month, and they're working closely with the minor injury services that have been set up Neville Hall Hospital, YYF and the Royal Gwent, where people with minor injuries can get outstanding care quickly without undue waits and delays. The revised role of the ELGHs is going to continue to develop. These are hospitals at the centre of communities, and we're always looking to see how we can tweak and adjust the services that we provide closer to people's homes, so that we make sure that the population of Gwent gets the very best service possible. We're well aware that the opening of the Grange has put a burden on some families, particularly those who live far away from the hospital, and we continue to work with other stakeholders to try and improve access whilst also developing services closer to people's homes. Next slide, please.
Back to you, James. Yeah.
So that concludes my part. I'd like to hand back to my colleague.
Thanks very much, James. That's really helpful. So just briefly, in terms of the last one about the last bullet, so was the case that changes around how we compare to others. Our main focus is on our own performance and how we are doing against our own expectations. But it is important to keep an eye on how we do relative to others who are in the same position as us. And as I mentioned, in nearly all metrics, planned care or urgent care, we are generally in the top 2 or 3 of the 6 main health boards, with the last 6 months seeing us having the best of the group in terms of 4-hour performance, even though it is way off where we would like that to be. So again, it's reassuring that we're not the only system under pressure. We are actually holding up relatively well, given the context all of us in Wales are working with. So just as a very brief summary of the next slide, thanks Dan, is, we've had a significant challenge opening a new hospital and introducing a new model of care in the middle of a pandemic. We've absolutely delivered the key benefits of an early opening to respond to COVID, and already delivering some of the key benefits, recognising there's still much more work for us to do. The strong indications of year 1 is that we are seeing improved clinical outcomes and system resilience and workforce sustainability in the areas that we knew were struggling. As I said, I mentioned the ELGH and the out of hospital models is where we want to focus a lot of our attention now. Particular focus and effort on patient experience and improving that. Looking after our workforce after such a huge challenge. And all of these are covered in our integrated medium-term plan going into 22-23. So thank you very much. Pause at that point. And I know it was a comprehensive report, but I think it's a very high area of interest that was important for us to cover.
Thank you, Nicola and James, for that very helpful overview. I'd like to ask the Interim Director of Finance, Performance and Value-Based Healthcare for the overview on the financial accounts for 21-22, please.
I'm not the first slide, please. There's a general overview today. I'm going to provide an overview on our revenue and capital performance as an organisation, and also a review of our charitable funds held on trust as well. So if I start from a governance perspective, the financial accounts for 21-22 have been reviewed, signed and certified by Audit Wales, providing an external assessment of our accounting procedures and performance. The opinion on financial statements, to summarise, identifies that they provide a true and fair view of our operating costs, have been properly prepared in accordance with accounting standards, and in addition are in line with NHS Wales directions. That's a positive outcome for us. In terms of an opinion on regularity, we have got qualified opinion on regularity. However, it is applicable across all of Wales. On the basis of this opinion being qualified was because we were able to actually quantify a provision of the implications of a ministerial direction that initiated from an issue in 1920, problems where some of our medical staff were not able to take additional work, for example, to help deliver improved waiting times due to pension tax regulation changes. And in order to help ease the burden and improve patient care, the First Minister issued a direction for adverse pension impacts due to the tax law at the time, where we would recompense clinical colleagues at the point of their retirement it did undertake additional work and it had a tax impact for them. So that was for 1920. In 2021, UK tax allowances changed, so it's specific to 1920. As a result of that, the Auditor General for Wales has determined that that was potentially tax planning and tax avoidance, and has hence identified the regulatory opinion on us and other organisations in NHS Wales. However, that risk and implication is for Welsh Government, because that's where the direction came from. Next slide, please, Dan. I move on to the key performance issues from a financial perspective for the Health Board. On the left, identified a revenue resource limit. So revenue expenditures, generally expenditure on our operating basis of services to provide care for patients. And in terms of our financial duty, we have a requirement to meet the revenue resource limit on a rolling 3-year break-even duty basis. 21-22, we achieved a small underspend of £249,000, and our 3-year rolling basis identifies a surplus of £526,000. There was, I think it's worth noting, for doing 21-22, achieving a balance and break-even position of that on the basis of over £1 billion worth of expenditure was quite challenging, largely due to the uncertainty and the operational pressures of responding to the COVID-19 pandemic and the acute pressures that we're seeing now as we're coming out of that, which affected most of the latter part of 21-22. In terms of our capital resource, capital is our expenditure on things like buildings and more expensive equipment. And we have, again, responsibility to balance over a rolling 3-year period. In 21-22, we achieved a small surplus of £50,000 with a rolling 3-year position of a £91,000 surplus. Thank you. If I can have the next slide, please, Sam. So this slide is a very high-level overview of the sources of allocation and funding we receive and the applications in terms of what we spent our funding on. The board received during 21-22 spend approved limits in terms of allocations of 1,599 million, so approximately £1.6 billion. It's worth noting that £180 million was received non-recurrently to support the organisation meet the demands and responses required to support patients during the COVID-19 pandemic during the year. Additional income from other sources was 109 million. So our total resources available were 1,708 million, approximately 1.7 billion. So how did we apply this? So in terms of expenditure, we applied it to primary care services to the value of 293 million, predominantly on general medical services from GPs, services they provide in the community, and prescribing costs from GPs. Hospital and community services is the hospital services that we provide and through community hospitals and community services. And that was predominantly on staff and non-pay goods and services. So staff accounted for just over 700 million pounds of that element. And then other providers of healthcare, the third sector, 463 million pounds. A significant part of that was spent on specialised services through WISC of 177 million, and other provision of services from other health boards and trusts, just over 100 million. So hopefully the graphs on the right provide clear direction in the trends of spend. It's worth drawing out as well that part of our hospital spending, you'll see a peak on the right, is to do with depreciation, which peaked in 2021, which was the year that we opened Grange Hospital. There were specific exceptional depreciation charges as a result of that new build being revalued. If I can have the next slide, please. So what I've attempted to do in this slide is describe how we used those resources and what did we deliver as an organisation for patient benefit. So there's I've got a few elements identified, and I'll draw out a few of relevance, I suppose, is in terms of GP attendances, all types in terms of services in the community. Approximately 2.1 million attendances have been estimated from the information we have. 511,000 district nurse contacts in the community. 800,000 outpatient attendances. 16.3 million prescribed items within the community. So that's GP prescriptions. 65,000 inpatient treatments. 38,000 day case treatments. 180,000 ED emergency department and minor injuries unit attendances. And all that supported and driven by 500,000 bed days being provided. So I won't go through the rest of them, but there's a sense of the scale, hopefully, of what we're providing and how we're applying our resources for patient care. Next slide. So moving on to our charitable funds held on trust. So how we get our funding for the trust is predominantly through generously donated resources to the Health Board Charitable Fund, largely from grateful patients or their loved ones or the wider community. And we generate some income from investments and sponsorships. So the objectives of the charity is such: we apply the resources available for the benefit of the National Health Service and for public benefit. So in the box there, just for clarity, the trust shall hold the trust funds upon trust to apply income at their discretion so far as permissible capital and for any charitable purposes or purposes relating to the National Health Service. So that's the rules in which it operates. The corporate trustee is the actual health board, and the executive directors and independent members share responsibility for operating the trust fund in line with those rules. The board delegates its governance work to the Charitable Funds Committee, who are aware of the duties and the rules in which they need to operate. Could I have the next slide, please? So presented here is how we utilised our expenditure and where that expenditure has come from. So the expenditure is funded from income, and this year we received £981,000. And the pie chart on the left describes where the sources of those donations come from. Sorry, the source of that income come from. So predominantly from donations, 41%, close to £400,000. Investment income identified is 187,000 and legacy 770,000. And we have additional funding from grants from other NHS charities, including some from the Sir Thomas More Fund, and also from work that people do for sponsored support for charities, including our CHC team, who organised a sponsored zipline challenge to support the charitable fund. In terms of expenditure, the significant chunk here is around purchase of equipment, 37%, and staff education and welfare, 24%. And key elements of what we spent on money, I'll present shortly. And the net charitable assets at the end of the financial year were £5.9 million, £500,000 increase over the previous year. But please note these are subject to audit, which will be performed by Audit Wales later in this year. I can have the next slide, please. So where did we spend our funding? We spent our funding on the areas identified: medical research, £3,000, purchase of equipment, £339,000, and that was on equipment to support dementia, renal care, cardiology, and upper GI services, amongst others. Buildings and refurbishments, £31,000, patient education and welfare, £191,000, staff education and welfare, £224,000, and that included purchasing hydration bottles as a little thank you for the staff to support and recognise their efforts during the COVID pandemic, and as I say, as a gesture of thanks. Fundraising costs of 3,000, support costs of 139,000. I don't have the next slide, please. And my final slide is an example of how utilising charitable funds has improved patient outcomes within Aneurin Bevan. So 2 reminiscence interactive therapy activities, Rita software, were purchased. They've been deployed in Ysbyty and Aneurin Bevan, and they're used to augment care delivered to older people and those living with dementia, Alzheimer's and learning difficulties, and to support them to reduce agitation, isolation, depression and delirium. And it's found to be particularly useful in a hospital where there are single-bedded rooms. So we used 2 of those, and they were approximately £7,000 each. Thank you.
Thank you, Rob, for that very helpful overview. I'd like to turn now to Nicola, as the Director of Planning, to give us an overview of our plans for 2022 until 25. Thank you.
Okay, thank you, Chair. I'll keep this fairly high level, but our integrated medium-term plan 22-20 to 25 has now been approved by Welsh Government, which is really pleasing. If we do the first slide, we just to set out our kind of clear kind of organisation's mission is to reduce the health inequality that's experienced by our communities through the improvement of population health. And we're very aware of the 18-year gap in life expectancy between our wealthiest and poorest communities, which is a significant concern. And we are concerned about how the pandemic may have worsened this. So there's a real focus throughout our plan about improving population health as well as addressing our issues. Next slide, Dan. We've maintained the life course approach to our plan, where we've got 5 priority areas, starting with every child having the best start in life, because we know how important that is in terms of longer term outcomes. Priority 2, getting it right for children and young adults. Priority 3, adults in Gwent living healthily and ageing well. Priority 4, around older adults supported to live well and independently. And priority 5, dying well as part of life. And making sure we've got respectful processes and dignity for people's end of life. We've then identified 8 strategic enablers that enable us to support the plans against those priorities, particularly focusing on experience, quality and safety, partnerships, research, innovation and improvement and value, the importance of that, the whole workforce and organisational development agenda, and we're very conscious of the pressures our staff have been under. Finance, digital data and intelligence, estates and regional solutions. So there's some clear plans against each of those enablers as well. So I'm just going to very quickly take you through some of the high level areas we're focusing on against each priority. In terms of every child has the best start in life, our main focus here is around good health and pregnancy, midwifery and midwifery services, the Healthy Child programmes and childhood immunisation. And against each one of those, we've got a clear set of plans with which we will be ensuring implementation and monitoring progress and improvement. And we've got a whole, I won't go into these in detail, but we've got a whole set of measures against each of those as how we will try to measure the outcome of the actions that we're taking. If we go to priority 2, Dan, in terms of getting it right for children and young adults, we're particularly focusing on adverse childhood experiences. There's a huge amount of research here, and we're keen to try to look at how we support people who do have adverse childhood experiences and how we can minimise those. There's a huge focus on mental health resilience, particularly for young people, and I think that's going to be especially important now as a result of the pandemic. Supporting a healthy weight, the importance of having healthy weight support and obesity programmes for children, and the whole transition. We know is a huge issue of children who've got needs transition to their adult services, and that's a key area of focus for us as well in our plans. And again, as the next slide shows, we've got a number of metrics that we will be using to measure whether we are making progress in this area in the way that we intended. So moving on to priority 3, and adults in Gwent living healthily and ageing well. There's a significant amount of work going on in this area. The main focus on maximising an individual's time. That's very much about people who are waiting either for urgent care or waiting for planned care. And we've got a huge programme of work against both of those areas to try to improve, reduce the amount of time people wait for services and to make sure they get the care they need when they need it. Living healthily and ageing well. This is very much looking at working with our communities to look after themselves and keeping people with a positive, positive contribution to their lives, and also mental health and well-being is a significant part of that. Transforming mental health and learning disability services. We've got a huge amount of focus on our urgent and crisis part of the service, as well as primary care, and maximising cancer outcomes. We know we've seen some increases, particularly in cancer referrals since the pandemic, and we've got quite a large backlog. So we're trying to ensure all patients are treated within 62 days of their referral, and that's a key focus for us going forward, as well as the preventative measures in terms of reducing the prevalence of cancer. Again, set a whole set of metrics of how we'll be measuring our success in this area. Priority 4, older adults being supported to live well and independently. And a lot of this work will be done in partnership with local authorities, particularly looking at prevention and anticipatory care planning, those high-risk patients that we know about. How can we proactively help people to stay at home and be supported at home? Effective care at time of transition. These are people when they move into the system. And also, how do we make sure that we've got the right services and support when people are in hospital and care homes? And then the priority 5, dying as well as part of life. We really are looking at people's advanced care plan and making sure we understand individual wishes when they're at their end of life, making sure that we've got a good education programme. Bereavement services is a key priority for us as well, supporting people when they've lost their loved ones. And really, we've got a care after death team who really are making a difference in terms of supporting families. And again, we've got a number of metrics we're looking at to try to, again, ensure we are delivering against these ambitions. The next slide identifies we've got 10 big priority programmes that we have very much focused on as a board, working with our team, with our operational clinical teams, and they are recognising emergency and urgent care, planned care, making sure enhanced local general hospitals are now optimising, picking up some of those issues I talked about under the 12-year evaluation of the Grange model. Mental health transformation. Decarbonisation is a key priority for Welsh Government and ourselves as a health board. Redesigning services for older people, which fits in with those priority 4. Maximising cancer outcomes, health protection, planned care, as Cathy mentioned, and our neighbourhood care network in terms of primary care. So we kind of got whole scale programmes of work, which we think are the areas that give us the biggest opportunity for change and to address many of our challenges. And then the last slide just sets out a number of ways in which we are making sure that we are enabling our services to deliver against these plans and programmes of work. We've got a very structured programme management in place to make sure that we've got the right focus on these projects. We've got good performance reporting, and we're trying to develop a much stronger outcomes performance framework. And we've got good governance across the board and across the organisation to make sure we know that we're doing what we're supposed to be doing, and we identify where there's risks and we go in track. So that's just a little bit about our process to make sure we are delivering against the plan. So I know I did that quite quickly, but I'm conscious of time, and there's a huge amount that we need and encourage those who are interested to read it. So thank you very much.
Thank you very much, Nicola, and thank you for that very helpful overview of our plans for the current and the next 3 years, which I hope you all in the audience found interesting, and we would welcome any feedback that you would wish to give us on those priorities and how we might best achieve them. Now we come to a really important part of this meeting, and that is the public's questions and answers. And I'm going to ask Dan and James to manage this on our behalf, as I think you have the questions that have been received.
And thank you. Yes, we do have some questions already submitted, and we also have a Q&A function on the meeting, which if people think of questions as we go along, you're welcome to type them into that Q&A section. You'll find the method to enter that Q&A section along the top menu bar at the top of the Teams meeting screen. So the first question comes from A. Akbar, and the question is, do you feel that the Health Board is meeting the needs of minority ethnic communities or individuals, i.e. cultural and religious needs? If yes, then in what ways are they being met? And can we go to Sarah Simmons for this question, who's our Director of Workforce and Organisational Development?
Thank you, James. I'll just check my camera. Is it on? I think it's coming on now. Excellent. In terms of meeting the needs of our minority ethnic communities, there are a number of ways which we are continuing to improve our understanding of how we can meet the needs of minority ethnic groups and individuals. And to set out some of that in a snapshot is around starting with our staff, who also form part of our communities. We've recently established a range of staff networks, including Voices at ADUHB, which is a specific staff group for our ethnic minority staff. We've also developed recently an integrated equality impact assessment process, which focuses on engagement, involvement and collaboration as key components when we're reviewing our services or new services and policy implementation. We're working in partnership with organisations such as Diverse Cymru, undertaking a cultural competence accreditation process in various areas within the Health Board. We also internally produce equality, diversity and inclusion newsletters, and this is also supported by a range of equality calendar events, which are open to staff within the Health Board and across NHS Wales. We also recognise the importance of the chaplaincy service, including lay chaplains for many of our religious denominations to meet the spiritual needs of our communities. We've recently looked at catering services and identified how we can improve these. Importantly, the Health Board is developing its response to the Welsh Government's anti-racist action plan and linking to existing key documents such as our strategic quality objectives, our workforce race action plan and our recently agreed people plan. Fundamental and a core feature of all of this would be to ensure the intersectionality is considered across all of these plans and actions moving forward.
Okay, thank you, Sarah. Anybody else like to address that question? No, okay. Thank you, sir. Sorry, James, over to you.
Thank you. I'd also like to highlight a piece of work being undertaken by one of my colleagues who has been working particularly with doctors who are international medical graduates. We're working in partnership with the GMC to make us one of the most welcoming employers in Wales, and as part of that we have designed with the GMC a bespoke induction programme and produced a welcome handbook for international medical graduates that helps them navigate their way into an unfamiliar health service and an unfamiliar culture. And it's something that we're committed to doing in the long term.
Thank you, James. Next question, please, Smith.
Okay, thank you. The next question comes from Nikita Lloyd, and Nikita has asked a question regarding flexible working. Across the Health Board, overall, do you feel flexible working is fairly available to all departments and job roles? And I believe this is another one for you, Sarah. Thank you.
Yeah, we have an established flexible working options policy and guidance, which is again available for all staff across the Health Board. The scope applies to all of our staff members, and applications are open to all departments and job roles. However, as you would expect, each application is required to be considered on a case-by-case basis. Whilst we don't centrally record the applications because they're very much locally owned. What we do know is that just over 50% of our workforce work on a part-time basis. So this suggests to us that flexible working options that we offer are being taken up. And some of those options include part-time working, job sharing, term time working, annualised hours contracts. And we also support flexibility with a range of other policies, such as allowing staff to purchase additional annual leave if they've got particular requirements, employment breaks, and also flexible retirement policies. In addition, we have for a while been promoting an agile and hybrid working environment, which has really taken off over the last couple of years with the introduction of more technology in terms of our working practices over the pandemic. And we have now recently introduced agile or hybrid working framework, which we understand that allows staff more flexibility to work from different locations, which may support their work-life balance. And we continue to promote flexible working opportunities across our workforce.
Thank you, sir. James.
Okay, thank you. On to the next question. This one comes from Suzanne Thomas. Thank you, Suzanne. Suzanne asks, with regards to major trauma patients who have suffered traumatic brain injury, either those repatriated from the major trauma centre or treated at the Grange University Hospital trauma unit, are there plans to develop and improve services with acute rehab and a potential repatriation landing pad? And I think we'll go to Dr. James Calvert, Medical Director, for this one. Thank you.
Thanks, James. So at the moment, we've got a relatively small community neuro rehab service, and they are very much focused on trying to reduce the time that people with brain injuries spend in hospital. So at the moment, their main job is to try and support people to be discharged directly from the major trauma centre at Cardiff and Vale to their own homes to avoid the need to be repatriated to an additional hospital. So at the moment, there are no changes to the Health Board's position on developing a repatriation landing pad. The AVUHB major trauma patients are either discharged directly home from the major trauma centre or are repatriated according to the South Wales Major Trauma Network protocol to the ward that best meets their needs, a process that's managed very ably by the Health Board's major trauma coordinators. Having said that, though, we recognise that there are synergies for patients with acquired brain injuries against those with conditions such as stroke. And the Inpatient Occupational Therapy Service has recently undertaken a review of the resource required to support people with brain injury who are admitted to GUH, and their results are providing us with very useful information to help us with service planning. And we're also very aware that there is an All Wales specialised rehabilitation strategy in preparation, which we would aspire to align to closely.
Okay, James. And we are also reviewing with our colleagues in Cardiff and the Vale and Cwmtaf the outcome of the establishment of the major trauma centre and the whole pathway of people with brain injuries and other damage caused from major trauma. So we should have those results very, very shortly.
Thank you.
Which will be helpful.
Thank you.
Next question, James, please.
Okay, thank you. The next one comes from Jane Carroll. Jane has asked, what is the Health Board doing to ensure safe staffing access across all clinical teams, especially those without coverage within Section 25B of the Wales Staffing Levels Act? I believe we're going to start with you, Sarah. Sorry, apologies. Linda Alexander, over to you.
That's fine, thank you. And just to provide some clarity, when people who are maybe not so familiar with the Nurse Staffing Levels Wales Act, the legislation doesn't only apply towards who sit under 25B, it actually applies to all areas where we provide care. And I think the Health was really clear in their responsibility to take all reasonable steps to ensure we do have appropriate nurse staffing levels, regardless of where patients are placed, and not just those sitting under Section 25B. The only difference is with 25B is that we are required under legislation to report that to Welsh Government. I think as a health board, we have taken many measures to ensure all reasonable steps are taken to ensure appropriate nurse staffing levels. However, we do fully appreciate the significant workforce challenges that we're currently facing. So in order to support safe staffing levels, we have put the following in place as a health board. We've got a ratified nurse staffing operational framework and escalation policy, and the purpose of which is to standardise and inform staff groups of their responsibilities, but also of their processes and procedures to ensure appropriate and careful consideration to nurse staffing levels in all areas. And specifically, the overarching duty of 25A is referenced within the policy. We've got a weekly reporting process and escalation policy within the health board, whereby we report any staffing deficits and consider any shifts that are filled and unfilled by registered nurses and healthcare support workers against our planned rosters. We also take into consideration the amount of agency we're using versus our substantive staff, as that gives us a good gauge in regards to quality, safety and continuity of care. We've also established registered nurses and healthcare pools across many of our sites, again, not just for 25B wards. They've been implemented into mental health, into community and into acute hospitals as well. We've got a workforce tracker which details progress on recruitment, agency, turnover and absenteeism. And again, that's considered right across the health board and not just for 25B wards. We do formal reviews of nursing establishments for all areas, and you may have seen that we've had significant funding put into our ED and minor injuries units and our surgical assessment units, which don't actually sit under 25B of the Nurse Staffing Act, but we've realised the importance of ensuring an appropriate workforce in those areas. Just a couple other points just to give some assurance in regards to the fact that we do apply legislation right across the health board. We've got clear divisional escalation procedures in place. We've introduced incentives to support rosters, which are available to all staff in all areas. We have engaged significantly in internationally trained nurses, and we've just had a successful recruitment campaign into our community hospitals, some where we haven't been successful previously. And we've now got 11 internationally trained nurses starting up in Yam. We have at times had to reduce capacity in order to maintain appropriate staffing levels, but that's after every other avenue has been considered in order to make sure our staffing levels are maintained. And just lastly, we've introduced new and innovative roles against all different specialities, as we've had to really look at a prudent approach to how we manage our nurse staffing levels whilst facing nationally recognised shortages of nurses. So hopefully that will answer your question.
Thank you, Linda. James?
Okay, thank you. Jane has asked a couple more questions. So the next one is, what contingencies are there to reprioritise services should another COVID wave occur? And what plans are there to deliver autumn 2022 vaccination programme within Gwent area? So if you would come to our interim chief executive, Glyn Jones, for the first part of the question around reprioritisation of services, and then we'll hand over to Dr. Sarah Aitken, Director of Public Health, to answer the vaccination part of the question.
Okay, thank you for the question. I think first of all, it's important to say that we do have the ability to reprioritise services as a health board. I mentioned earlier on some of the support that we'd had from Welsh Government, and I think this is a good example. Welsh Government reinforced during COVID the fact that health boards across Wales could take decisions locally to prioritise services given some of the extreme service pressures that we were seeing, such as COVID. This was called a local options framework. But it actually reinforced what we were able to do as a health board anyway. But I think it was really helpful that that was done across NHS Wales. So we're able to do that. I think it's important to say that any decision that we take to reprioritise any services needs to be done based on good evidence, proper risk assessment, impact assessments, and that we engage locally where appropriate. So there were instances last year where we did that. And if you take the Omicron variant and wave of COVID back in last sort of November, December time, we were given probably about a 3-week window within which we needed to offer everybody who was eligible a vaccination. So that meant that we had to very quickly take a decision to redeploy staff who could vaccinate patients in a very short space of time. So we undertook an assessment that said, actually, where could we safely redeploy those staff in order to achieve that? That also meant that in some services, by doing those risk assessments, we were able to say, actually, no, it's important that we still protect some services. So hopefully that's a good example of where we've had to prioritise services. And again, in the future, whether it's a COVID wave or whether it's other extreme service pressures, we have that ability as a health board to do that again. But I think it's important that we go through that proper process, and clearly any decisions that the board take are based on that good evidence. I hope that answers the first part of the question, and I'll hand over to Dr. Sarah Aitken to answer the second part.
Thank you. I think in a way we could have answered it the other way around, because being the Director of Public Health, prevention is clearly the best approach. And in terms of anticipating what's coming this winter, we need to be anticipating potentially another wave of COVID. We've got one at the moment, and the Omicron variant seems to be mutating and evolving. And so while it continues to do that, then the vaccination programme can evolve with it. And there are vaccine trials underway to develop vaccines that are more specific for the Omicron variant. The other thing we need to anticipate is the return of influenza, and the influenza season in Australia is, as many thought it would be, is quite significant, and therefore we need to assume that may be the case for ourselves. And so we have effective vaccines for both, and the most effective thing we can do is vaccinate all of the eligible population ahead of the virus season starting. And the eligible population is the same for both. It is everybody over the age of 50 and those in clinical risk groups below the age of 50. So we do have well-developed plans. Over time, I think we will get to a combined programme, but we're not there at the moment because the flu programme is historically delivered by general practice other than for our own staff. And therefore the flu immunisation programme will be delivered by general practice in the normal way. The COVID immunisation programme will be delivered by general practice for everyone over the age of 65 and will be delivered through the mass vaccination programme for those under the age of 65. And we have got detailed workforce plans for the numbers that we know about. Inherent in the question is planning for uncertainty, but the known eligible group for the COVID vaccine is 291,000, and I think it is likely to therefore only be the sort of 16 to 48 age group who we might get asked to immunise quickly as we did last year, because with the under 16 and under, they've only recently completed their primary programme. So I think having plans to do most of the eligible population in advance of the virus season is our best preparedness. But we are working up the contingency plans in anticipation of what happened last December. so that we've got the plan ready to go should we need to use it, drawing on staff who are potentially available and not delivering clinical services, and that's with more time to plan. That we're working that through, and we've got an executive team session on that coming up in early August.
Thank you, Sarah, and thank you, Lynn. James, are there any further questions?
There's one more, Chair. I believe this is the final one that we've had. The question is, how is staff welfare and well-being being supported as staff continue to see exceptional demand on our services whilst supporting the recovery plan? I know we've come to Sarah quite a lot with these questions, our Director of Workforce and Organisational Development. So Sarah, would you mind answering this final question, please?
There are a number of ways in which we support staff welfare and well-being and staff health. And this is a central pillar of our recent plan, which we've recently agreed. And there are a number of actions to support this very important area. Some of the ways in which we support is through our occupational health services and through networks and signposting to internal and external services. And we're always continually looking at new ways to develop support mechanisms for staff. And we've recently introduced a specific mentors network for staff, which has been very well received. We also give specific support for staff and managers in terms of absence management, recognising that there are times when staff need to take time away from work for a number of reasons. And we're continuing to provide the tools and the skills and expertise for managers to support staff going away from work for various reasons. We have an established employee wellbeing service, which has an employee psychological therapy service and a team support service, and that provides bespoke support for individuals, teams or departments who require it. And we're also looking at plans to further develop our wellbeing service with an ambition to create a wellbeing centre of excellence in the future. And we recognise that especially through the past couple of years, it's been extremely difficult for staff. And we've taken an approach where we've surveyed staff specifically around their wellbeing throughout the pandemic. And we've used the results of those surveys to have a deliberate response in terms of the interventions that we've made, either on a team basis or an organisational basis. And we've evaluated those approaches in terms of their success and in terms of their value in continuing with some of the pathways that we've created. And we also recognise that sometimes staff may not respond to a survey, and sometimes staff may not be absent or feel the need to access one of the services that we have. So as an executive, recently we agreed a programme of work to connect with all of our staff across as many of our sites, teams and departments as possible, and have launched a People First reconnection and re-engagement campaign, which has been in place for some months now, and we're continuing to go out, speak to staff, importantly listen to how they're feeling and listen to their experiences so that we can further develop our support networks.
Thank you, Sarah. I think that concludes the question session. Yep. It's just for me to finally thank you all very much for attending our AGM, and thank you to the presenters, and particularly to those of you who submitted questions. I do hope you found it informative, interesting, and we look forward to receiving any feedback you would wish to give us. As you can tell, I hope, we're not complacent about the services the Health Board provides, and the board and the staff teams will continue to strive to address the problems created by COVID-19. We're all very committed to deliver excellent care to our populations, and we're very lucky as a board to have such competent and conscientious staff and I'd like to thank you all once again. We welcome feedback from patients and the communities, and we really wish to hear from you in a very structured way so that we can use your experiences to redesign our services or to improve the care that we can provide. We will be improving the way in which we collect patient experience and experience from communities in order to inform our planning going forward. But once again, thank you very much indeed for attending and for your interest in our organisation and its services. Thank you.